بسم الله الرحمن الرحيم. أهلا وسهلا بالجميع. اليوم we have another night, another evening, another education by the Iraqi Australian Medical Association, the scientific committee, the webinar committee. Tonight we have a couple of brilliant doctors, young doctors, specialized mainly in dermatology. We have Dr. Zeyad Al-Dabbagh and Dr. James Al-Israeli. They're both Iraqis, and they will present a couple of lectures about skin. We will start with Dr. Zeyad Al-Dabbagh. Dr. Zeyad Al-Dabbagh is a consultant dermatologist. He's fellow of the Australian College of Dermatology with extensive experience, 19 years in dermatology. He graduated from Mosul University. He has a training also in Jordan, King Abdullah University Hospital. He also spent time in Canada, and he has fellowship in the University of Toronto. We're lucky to have him in Australia over the last couple of years, and he practicing currently based in Melbourne and consulting his own clinic at Latrobe Private Hospital in Bandura, as well as Sinclair Dermatology in East Melbourne. I welcome Dr. Zeyad. You can present your seminar.
Thank you very much, Dr. Issam. ترى جيمس آل إسرائيل مو جيمس الإسرائيلي. بعدين راح يصير رشيد جيمس. So let me just open this. So do you guys, everybody see the slides clearly?
Yep.
Perfect. So hello everybody. Nice to meet you all. Today we're going to present, actually when we were in the first IAMA conference, I presented the first part of my lecture. Time unfortunately ran short, so I couldn't do the second part. So I thought maybe I kind of do the second part today. Hopefully we could complete that. So the lecture topic would be Skin Deep, Tips and Pearls for Busy GPs. And I know it's a little bit harder to do it through Zoom, but please, I know there is you could raise your hand, there's that sign, and I think we could get some help from the people in the background, and if there's any questions on the spot, I'm happy to stop. So I moved to Australia around 2 years ago, started in Sinclair Dermatology, where I'm working now in East Melbourne and Pascoe Vale clinics, and I haven't started my clinic yet in the 360 Dermatology at Latrobe, hopefully starting in next November. Funny story, when I first came to Australia, I knew nobody. And James, who I know from back in Dabbagh, where I was a university lecturer there, I knew him more than 12 years ago, and I didn't know that James was here. So he was at the clinic where I was working, and by coincidence, he saw my name, the sign, and he asked about me. He knew a dermatologist there, and he was wearing a mask, and I didn't know him initially, and then he took off the mask. He's like, I'm James. So James introduced me to most of the physicians here through IAMA, and now I have a lot of colleagues and wonderful friends, and I'm sure there is much more to meet, much more doctors to meet, because mashallah, we are a lot. So I always like to start with Sir William Osler. He's my role model, historic role model of dermatology, although not officially a dermatologist, but he's considered one of the four fathers of medicine with Hippocrates from Greece. And he always used to say, see and then see again, summoning the importance of using your eyes as a visual tools, trained initially in dermatology in Vienna, which was the capital of modern dermatology, by Kaposi, who we named Kaposi sarcoma after him. And then he's originally from Canada, moved to America and founded Johns Hopkins. And he was one of the first doctors who knew the importance of bedside manners and the importance of clinical skills, using your eyes as you can see, multiple quotes. The whole art of medicine is observation, and the skin is often the first page of a book of diseases. So he, in his first textbook of medicine, he revolutionized actually the way we look into dermatology by introducing many diagrams and photos at the time, which was not a known thing. Dermatology was still not its own branch. And then later on, he kept on insisting on the importance of using patterns and how to describe dermatology using our own lingo. Because many of the times when we get referrals, we used to joke when we were residents from other specialties, like, middle of the night, it's always a maculopapular rash, etc. So obviously not everything is a maculopapular rash. We use a lot of terms, but for us, honestly, many of the times, not always, it's a clear cut. So my professor in Toronto, Dr. Neil Shue, used to say, joking, that either you would know it in the first couple of seconds or you won't know it at all, the disease itself. So always, I think it's very helpful to know what kind of describe your primary lesions, the secondary lesions, then put the disease in a group. Because although we have around 3,000 diseases in dermatology, and up to 10,000 if you take into consideration rare diseases in orphan registry, but we only have 11 groups of this that they could fit. And even if you don't know the actual disease, just fitting it in the right category would be very helpful in management and also your treatment plan moving forward. So today, last time I talked about the papulosquamous disorder. Today I'm going to talk about the eczematous, and if we have time, the erythematous disorders. So we said that the difference is very clear cut between psoriasis on the right. I'm not so sure. Do you guys see my pointer? Let's try with this one. And laser pointer. Do you guys see the pointer or no? Yeah, perfect. So psoriasis on the right, obviously well-defined, scaly, thick. Eczema, on the other hand, the prototype is usually erythema, edema, not well-defined, and you can't put a line, you can't draw a line out of it. Eczema itself as a word existed for more than 2,000 years now. It's a Greek in origin, so if you tell any farmer or anybody who's even not, an educated person, eczema in Greece, they will know what eczema means, not just because they know the medical term. Obviously, we use eczema and dermatitis interchangeably now, and it means eczema, as you can see in the slide, over, out, boiling from the outside. So what's a dermatitic reaction pattern? You will have the erythema, scale, crusting, nothing specific. As I was saying, often it's poorly demarcated, and also thickening of the skin with greased markers. So some photos, because as William Osler said, photos are the best way to learn about dermatology. So eczema itself could be classified into acute, subacute, and chronic. This is a classic example of an acute eczema. Usually you have the weeping or the blisters due to the spongiosis or intercellular edema. Another photo showing acute eczema, and this is our infant stage atopic dermatitis, because in atopic dermatitis, I'm not so sure why it's kind of moving. So in atopic dermatitis, we usually have the infantile stage where it's mostly cheeks, and then you pass to an extensor surfaces, and then it goes on to the childhood where you have the flexures, and then the adulthood or the teenager years, because most parents usually ask us the question, will my child heal? And in 60-70% of the cases, yes, but many continue to have either low-grade generalized eczema, or they have it more accentuated over their hands and periocular areas. That's usually the outcome of eczema. This is a classic picture of a flexural eczema in the childhood. And here it's a subacute eczema. You could see a little bit of weeping and thickening of the skin. This is a chronic uh, this is a chronic stage of eczema where you see the lichenifications, like a bark of a tree, the shajara, and you see the excessive skin marking. This is lichen simplex chronicus. So whenever you see an adult with periocular dermatitis, the first thing you should ask, do you have history? Because the first thing we usually think about is allergic contact dermatitis, which is true. But remember when I said in adulthood stage, those who don't clear, one of the most common manifestations is periocular dermatitis. So always keep that in mind because it could not be, you don't need to refer them for patch testing. So they may have a little bit of overlap, but usually if they have history of atopic dermatitis, purely atopic. Same with the hands. Many adults clear their history of eczema when they're kids, but they continue to have like hand dermatitis due to atopy. Could be exacerbated by irritants or contacts, but again, it's important to always ask. Patch testing is always important. So whenever you have somebody with recurrent hands dermatitis, here in Melbourne, like Skin Health Institute, they have a patch testing clinic, so you could always send them. And at least it's not always a clear cut, but at least you could rule out a pure allergic contact dermatitis, and they may give them some helpful hints of what product they could use. Another thing, whenever you have, so nowadays, when I was a resident, they used to tell us that eczema, it's atopic dermatitis started in childhood and goes on. And now we know that there's an adult and late onset atopic dermatitis. So this person, first thing will come to my mind is eczema, right? But always, whenever you have it, especially in elderly, think about mycosis fungoides. So mycosis fungoides, here, what you will see is those dermatitic patches are a little bit atrophic, like a cigarette paper. I'm not so sure if some of you could appreciate, but it looks atrophic and increased skin marking. So always, it's a good idea to take a couple of biopsy, send them to the lab, put eczema to rule out CTCL. And they will do the immunohistochemistry markers and also the T-cell gene rearrangement studies to rule out this. Fortunately now, so obviously with eczema, we all know, most important, we always tell them grease for peace. That's the most important thing because of the mutation in the filaggrin. You can't maintain the barrier of the skin to hold the water. So obviously moisturization using topical steroid or calcineurin inhibitor. But obviously when we see most of our cases that you guys send us, usually they're severe. And thank God nowadays we have a lot of agents that we could use with a lot of success rate. Before we used to use methotrexate, cyclosporins, but nowadays we have a lot of treatments. The two that are approved in Australia for atopic dermatitis, Dopixent injections, which is a biological treatment that blocks interleukin 4 and 13, which is responsible for aggravating eczema, and Rinvoq, updacitinib, which is a JAK inhibitor. I usually like to start with Dopixent. It's been around for around 8 years. I used it since the start back in Canada. It's only been, I think, in Australia for around 4 years and still only approved for 6 years and above. In Australia, although in North America, it's approved even for 6 months now. It will soon change. But basically, if you want to know if your patient would be suitable for these, a rough indication would be if he has or she has 10% body surface area, that will usually translate into what we call an EASY score. So we calculate this. They need a certain score of a PBS to cover these. Obviously, very expensive. We're talking $20,000, $30,000 a year, but they will cover them. But if the patient has 10 pounds of eczema involving the body, most likely they will hit that score. This photo, I obviously wish that there were more time to interact, but I will just go and say the diagnosis the right way. So follicular accentuation in darkly pigmented skin. Always think about follicular eczema. Patients who have darker skin color, atopic dermatitis usually present in a papular or follicular eczema, which many may misdiagnose or not know what the diagnosis is. Another one where maybe one of the few exceptions where eczema is well defined is discoid eczema. We said that eczema is usually not well defined, but in this case, that's an exception. The theory that it starts as whenever I'm losing my mouse, something's happening. It starts as staph infection of the hair follicles that activates the immune system, and you could see how it's accentuated around the follicles, and then you have this reaction of discoid eczema around it. That's why always with these patients, especially in kids, giving them a course of antibiotic will really help reducing that super, like Staph aureus super antigen role, and also using some potent, very potent steroids, because the inflammation is deep down the hair follicles, and usually moderate steroids won't do anything. Again, another photo of discoid eczema. Sometimes it's a little bit tricky, not as easy as this photo to differentiate psoriasis from discoid eczema. But obviously, as you can see in this photo, psoriasis, you have a very adherent silvery scales, and you need to bring your slide and kind of scrape them all, very adherent. Here, they're very flaky and pityriaciform, مثل نخالة. So it's very obvious. And also, when you kind of remove the scales, you'll see pinpoints of bleeding, and that's what we call Osbitz sign, due to the dilated blood vessels and the suprapapillary thinning seen in psoriasis. Our friends in pathology will know that. So, again, I'm sure all of you would know this, Pompholyx. So it's a variant of eczema we used to call dyshidrotic eczema, where we believe that there's a problem in the sweat glands or obstruction causing that inflammation or eczema, usually presented at deep-seated papules, intensely itchy on the sides of the fingers. Whenever you see a patient with Pompholyx, always ask. Pompholyx represents what we call an id reaction, ID. What's an id reaction? It's many variants of eczema could be precipitated by infections. You will be surprised how many patients with Pompholyx have tinea pedis or onychomycosis, which is causing their recurrent Pompholyx. And even discoid eczema could be an id reaction due to an allergic contact dermatitis. For example, many patients who have leg ulcers using topical antibiotics or dressings that have some substance that they're allergic to will have autoexemization or ID reaction. Again, Pompholyx, dyshidrotic eczema, sometimes it could be very severe where you need to give them some long course of steroid. I've started actually to put a lot of my patients on Dupixent, the biologic agent, and it's working very well so far. I'm knocking on the woods. I have only one patient who did it. This photo, if you have a close look at it, it has two things going on here. So you'd have this eczema, ill-defined erythema scales, but also you see these urticarial. I'm not so sure if you can appreciate it. There's a lot of urticarial papules. And whenever you see in a patient urticaria and eczema together, it's scabies until proven otherwise. The only disease that could cause a type 1 hypersensitivity reaction, urticaria, and a type 4 hypersensitivity reaction is scabies. Obviously, not always it's an easy, straightforward diagnosis, but obviously itching at night, having the burrows where the lady might put the eggs. Apparently, the males of the scabies, fun fact, they mate with the lady at the beginning of the tunnels, and then they jump on the skin and they die because they can't live inside of the human body. That's the sole purpose of the male, wandering around to find the female, and then he commits suicide. So the ladies put the eggs there, and you would imagine that there's a lot of mites rolling over. No, it's actually 7 to 12 parasite or mites, female parasites in the body causing that reaction. But it's that hypersensitivity immune reaction that is causing all that issue. A very good pathognomonic sign for scabies is the rubbery nodules. In the guys, it's over the genital area of penis in almost 99% of the cases. And in the ladies are on the areolas or inside of the axilla or genital areas. These represent areas where the antigen of the scabies was there, then stimulated the immune system to cause a pseudolymphoma or a granulomatous reaction. Also, an important thing to keep in mind, these don't go away very fast. The scabies might go away and the itching goes away. These means could stay months and months, just to let your patient know, because sometimes they keep on coming back thinking that they still have scabies. Norwegian scabies, which we see obviously in bedridden patients, very ill, has that powdery, scaly precipitation over the hands mostly. Another thing that I wanted to mention with scabies, most of the referrals that I see are treated with permethrin. There is worldwide and in Australia also a very high emergence of high resistant trend with permethrin 5%. So although they used to say ivermectin is the tablets is the second line of treatment, I'm starting with ivermectin. I'm not using permethrin 5% anymore. It's good that we're not in the COVID era where our friend Abu Ivanka, Donald Trump, used to say that ivermectin clears COVID. Otherwise, we couldn't find any ivermectin because that happened in America for a couple of months where you couldn't even prescribe ivermectin. Even in Canada, it was in back order. So whenever you see this picture where you have multiple what looks like neurotic excoriations, mostly over the arms, hands, that's prurigo nodularis. It's considered a variant of eczema. It's actually considered more widespread lichen simplex chronicus. What happens here, it starts as a neurotic or a neurocutaneous disease. But later on, as the patient continues on picking, there will be release of what we call a keratinocyte stimulating factor that could thicken the nerves themselves, releasing interleukin 31, and the cycle keeps on going. So it's never ending. And you tell the patient to stop, it's difficult for them to stop. It could be associated with atopic dermatitis sometimes, chronic kidney disease, iron deficiency anemia. You have to also test for iron, very common one. Butterfly sign is something we see. You usually see the mid portion of the back that is clear because the patient obviously can't reach there. That's one of the signs. And hopefully soon, it's approved now, it was approved in Japan back in 2022, an interleukin 31, neolizumab, and Galderma now is working on it. So hopefully it got to the TGA, but it will be, I think, within a couple of months available, and it will be much more better than those classic agents that I was talking about. Obviously, straightforward cradle cap. I just put, which is seborrheic dermatitis. So just keep in mind, kids with cradle cap or seborrheic dermatitis, they're prone, studies shown 50% of those kids have a high likelihood of developing severe seborrheic dermatitis or atopic dermatitis when they grow up. So obviously, the classic signs are the nasolabial foam. We have those greasy yellow pityriaciform-like looking scales, retroauricular, also the frontal area of the scalp. The most important thing to understand here that it's due to a reaction from the Malassezia species that we have. So we always have Malassezia species, right? Dandruff caused by Malassezia. That's the most milder version of seborrheic dermatitis. When we address this, it's important to always reduce the burden or the load of Malassezia. That's the only way you can maintain a long time clearance. So it could be associated with Downs, Parkinson, HIV. HIV actually is an interesting one. I remember when I was back in Jordan, obviously Middle East, HIV is not very common, especially a long time ago. We had a patient with seborrheic dermatitis that didn't clear. We kept on giving him everything, starting from Roaccutane, isotretinoin, and then we discovered we did the HIV testing and he was positive. So that's something to keep in mind. When I was saying reducing the load, I like to give my patients a course of itraconazole, especially during the winter months, or fluconazole, and you just give them a couple of repeats. And obviously use the shampoos, especially the cycloparaxolamine, instead of the ketoconazole, as many studies found that it's less irritative. It's a broad spectrum antifungal and has more lasting results, reducing the Malassezia load and giving them those. Otherwise, they will keep on using the anti-inflammatories with no end in sight. How many minutes do I have, our coordinator? Because
your presentation is nice. I will give you another 5 minutes.
Okay, 5 minutes. let me run through the second group of disease, erythematous disorders. So rosacea is a prototype. Factors, nobody has been able to work out rosacea. They say it's a neurocutaneous vascular mumbo jumbo. Nobody knows whatever. If anybody knew, we'd have one treatment for it. Often you'll get patients who come to you with this, usually bags, erythema, sometimes in tears. It has a bad effect on the quality of life. And the most important thing, they have the new classification of rosacea. I like the older version of classification because you have to think rosacea from a 3D perspective. And you have to know which stage are you treating. So you have the erythema stage or erythematotelangiectatic, the inflammatory stage, the thymatosis stage or the nose stage, and then the ocular rosacea. Erythematotelangiectatic, you have first the flushing, then the persistent erythema with the stinging followed by telangiectasias. Usually, classically, it involves the nasolabial fold, right? And rosacea. And that distinguishes from SLE, which does not involve the nasolabial fold. And also central, so it involves the central area of the face. SLE, a butterfly rash, all the way to the lateral sides. So how do we treat that? So the treatments for this, because many times I see patients who come to me with Mitrogel or azelaic acid, right? The patient has to understand that this won't affect anything with this first stage. So usually you tell the patient light-based therapies and vascular lasers. I find treating patients with vascular lasers from the start, a pulse dye laser, will do a lot, even from the symptoms perspective, even if they have inflammatory rosacea. Just starting and combining the treatment from the start do miracles. Mirvasa is the one that I think is underutilized by our general practitioners. Brimonidine, it's adrenergic alpha agonist stimulator that causes the blood vessels to shrink. The patient has to understand that it's temporarily and it only lasts for 12 hours. But actually, it works very well. And many patients like it because whenever they have an occasion or a wedding, they put it on and their erythema is like 70 to 80% less. I wanted to say a couple of words of Rox Anderson, who I've met a couple of times whenever we had the workshop in Toronto, and he used to be a visiting doctor explaining and teaching us about lasers. He's the godfather of lasers, and his selective photothermolysis paper, which was published, believe it or not, in 1983, is still in full use. And it was our first, or the first actually article that made us understand how to use lasers in dermatology. And many of the lasers that we use now, it's thanks to Rod's understanding of lasers early on. So he said that a pulse of selectively observed topical radiation so multiple wavelengths, each wavelength could be utilized to damage a certain organ in the skin. So if you look at this diagram here, so what do we have in the skin? We have blood, that's the red diagram. We have the green, and that represents your melanin. And you have the water, and obviously. So the red, usually, you can see the absorption of the light of different wavelengths here. The maximum absorption is here around the 400, but also the melanin absorption is high. So that's why you would find here at 585 or 595, we use our pulse dye laser to treat rosacea because the melanin absorption is less, so you don't have any side effects. And obviously, there's a lot of other stuff that I love to go through, the spot size and the pulse duration, maybe on another chance. But what I wanted to say is, for erythematotelangiectatic rosacea, it actually works very well. You'll have a little bit of purpura when you rupture the blood vessels, but later on, you'll have some long-lasting results. Papulopustular rosacea, you have here the pustules, and here you have your azelaic, Mitrogel, or metronidazole, and Cilantro. I always kept saying in the second wave of COVID, after Donald Trump said, our friend Donald Trump said, not to use at the time the hydroxychloroquine for COVID, and went out of went out of the market. And then this came out, which is the ivermectin. So people were using the horse paste that they use for horses, and they used to actually swallow it and eat it. So I kept on saying as a joke with the dermatologist, thank God nobody knew that we have been using for almost 10 years now ivermectin. Otherwise, everybody would be using it like Vicks when the COVID happened. So I think cilantro ivermectin works much better than, there are many studies that show it work much better than metronidazole and azelaic acid. Systemic antibiotics, obviously, they work very well. But the problem here, we don't have in Australia the slow release. We have the 50 milligram doxycycline. We don't have the 20 and the 40 milligram in North America. I am very aware of the time. I could see you, Issam, so I'm just scrubbling in. We have the Phaimatus. Just to let you know, rosacea, one of the things you distinguish rosacea, it's the only disease that causes changes in the nose. So there's no dermatology disease that causes this, if you're not sure about the diagnosis. That accentuation or cobblestoning, thickening, could be treated with lasers, and also Cautery Morbihan disease is a solid facial edema. It's a variant of rosacea. Ocular rosacea could be associated in 50% of patients. So always ask about ocular signs and the treatment. Investigations, usually not needed, but always do an ANA and an ENA to differentiate lupus. Flushing alone is a warning sign. Obviously, if it's not physiological, you do your tryptase for mastocytosis, thyroid imaging, medullary carcinoma or 5-edge IAA, through our carcinoid tumor or the metanephrine, pheochromocytoma. These are all things that could cause flushing. Almost done. 5 more slides. Acne, obviously, sometimes it's easy, but you see the comedones. That's the most important. Rosacea, no comedones at all. And that's the way, although obviously in life, always it's not that easy. We have a variant called acne rosacea, which makes life not more beautiful. But I found those respond to isotretinoin. SLE, always, the butterfly rash, extends all the way to the lateral cheeks. And here you would notice it spares the nasolabial fold. Rosacea doesn't spare the nasolabial fold. Perioral dermatitis, 4 more slides, Issam. That's usually on the spectrum between rosacea and eczema. In the middle, here you would see eczema signs, right? So you have the dryness. That you don't see in rosacea. Many times it's precipitated by steroids by the patient themselves. And obviously you give the antibiotics, calcineurin inhibitor, and if failing, then Accutane or isotretinoin. Another thing that I want to say, sometimes these indurated solid lesions, whenever you have them, don't rush into acne and rosacea. If you have indurated granulomatous looking, think about the 6 L's of cutaneous lymphocytic infiltrate. What are these? Lymphoma, pseudolymphoma, lymphocytoma cutis, Gessner's lupus tumidus, sorry, there's a typo, lupus tumidus, no, there isn't, and leukemia cutis, metastasis from internal blood or solid organ tumor. Other things that could look like rosacea, you have here on the left, airborne dermatitis, eczema-like reaction involving all the face. Photosensitivity, you'll have sparing of the shaded area. As you can see here, these areas are shaded, so that's why there's nothing there. And management. Last slide. Basically, it's not as easy as it sounds, but I would say attack from all angles, explain to the patients all the stages, combine treatments like lasers, from the start, do the topicals, review their skin routine, pick some stuff that are not irritated for them because they have sensitive skin, and tailor the management for them. Thank you, and sorry for the super fast lecture, but we did it.
Thank you, Dr. Zeyad. أخذت مني وقت 3 دقائق.
Sorry.
بس يستاهل.
بس خوش محاضرة رائعة وجيدة، بس أتوقع يعني راح تكون هناك أسئلة كثيرة.
نخليها على المرة الجاية، مو مشكلة، خلي جيمس يكمل. We could do another one later on.
Dr. James Al-Israel.
تمام.
He's general practitioner with a special interest in skin and skin cancer. Many degree and certificate diploma in skin cancer, practical dermoscopy, certificate of dermoscopy. Like he has many, like more than 10 professional certificate in skin, in addition to his fellowship in the general practitioner. I welcome Dr. James. He's graduated from the Hawk, as Dr. Zeyad said, in 2011, and he came to Australia. We're lucky to have him since 2014. He practices mainly in the three places in Melbourne, Sunbury, Western Skin Institute, Spring Medical Kyneton in Victoria. James, you can share your slide and you can present your case. Thank you for your time.
No worries. Thank you. Just give me a second.
If you can do 15 minutes, will be great. 20 minutes.
That's fine. We'll be quick.
15 minutes will be great, so we can have time for the question, because I'm sure there will be plenty of questions.
Yeah,
thank you very much.
Yeah, thank you. Thanks everybody for attending tonight. I know you guys have everybody busy with families. Thanks for sparing the time. Thanks for IAMA as well. Thanks for Zeyad. Thanks for everybody. My name is James Al-Israel. I'm not as Al-Israeli. This is my Issam Gal, and this is my surname, and this is my real name.
I apologize.
No, that's completely fine. That's completely fine. A lot of people say, "This is your real name." I said, "Yeah, this is my real name. When I born, they named me James." So anyway, I'm a fellow GP. I do a lot of skin cancer. Always collaborate with Zeyad, ask him a lot of questions, annoying him, but I think that should be fine. So I work in three places. I work with dermatologist in Sunbury called Complete Skin Specialist, and I do my general GP as well in rural Victoria in Kyneton, and I work at Western Skin Institute at St. Albans as well. We do a lot of skin stuff. All right, let's start. So it will be skin cancer is very big topic, but as Zeyad said, dermatology is always big. So I'm trying just to touch on common points. This talk is for GP level. So as I know, there's multiple GPs here tonight. So we'll just touch base on common things, and if they're aware of the how to use dermatoscopy, type of dermatoscopy, and etc. So let's start with why we need to learn about skin cancer. It's especially we're living in Australia. Skin cancer is the most common cancer in Australia. It's got high mortality, high morbidity and mortality. If it missed, early detection saves lives. Like for the last 2 weeks, I think I biopsied 4 melanomas, early stages, which is perfect for the patient, for the health system as well, and for everybody. And as a GPs, we are the front line. Most of the patients, when they come for a consult, can we check this, doctor, for me? I have this spot, can you check it for me? So that's the idea where I start. Okay, I'm interested in the skin. I have some surgical background as well, so I like my hand skill. Used to use it. Beautiful. All right, let's talk about epidemiology. 2 in 3 Australians diagnosed by 70. So they have kind of skin cancer. More than 1 million treated annually. Melanoma, there's more than 16,000 cases per year. And as we know, high cost burden on the health system. Like if you get a patient who's melanoma metastasis, it's a lot of oncology involved, plastic involved, dermatology involved, and a lot of costs. So that's why I think it's good to have GPs who are interested in treating skin cancer to detect the melanoma early. All right. As I said, what's the impact on us as a GPs? Frequent presentation. Okay. Yeah. A lot of patients can, and the other thing is prevention and early detection. How we do that? We use our toy, which I say it's called our dermoscopy. Okay. Bit of general talk about what skin does or anatomy. So we have, epidermis, and it's the barrier, the keratinocyte. Then we go down is the derms, support and vessels, nerves, subcut fat, and then the pigment cell, the melanocyte. And this is, this is typical textbook, from medical student, that we got the hair here, epidermis, derms, and then adipose tissue. So this is the epidermis, derm, and hypoderm, and subcutaneous layer. What are the skin function? Yeah, why we have skin? All right, skin protect us from infection, from UV light, thermoregulation, vitamin D synthesis, and all the nerve endings are there. So that's why vitamin D is very important, and we ask people, especially most people from our region, Middle East, they always low in vitamin D. Beautiful. Okay, let's talk something about the skin and then why the cells are relevant to us. So if we look at this diagram, there's two types of cell. There's keratinocytes, which are responsible for developing BCC and SCC, and there's the melanocytes, this one, which is responsible for melanoma, basically, from the name. Okay. What are the risk factors? Who will get skin cancer, like myself or somebody else, or what are the risk factors? UV exposure is one of the most important risk factors, and the other thing is fair skin, genetic factors, immunosuppression, and age, and the other thing is male. I just want to highlight immunosuppression because any patient who is on any kind of immunosuppression medication, and especially the patients, and the other one is the one who's transplant patients. Transplant patients, they have high risk of developing SCC. I have one of my patients, she is 67. She had history of renal transplant, kidney transplant, and then she comes to me every 3 months for a skin check. I did a biopsy on her, on the scalp, and then she came 3 weeks after that. She had lymph node metastasis, even though it was a well-differentiated squamous cell carcinoma. So she ended up having a big dissection and then nerve palsy, and then I feel sad for her. Yeah, but that's because there's a lot of patient nowadays in immunosuppression. So I just make sure when patient come, if you're not interested in skin as a GP and your patients are on immunosuppression, I think it's a good idea to highlight the point of doing a skin check, which I think is very important point. Age, anyone above 65 more prone, and it's more in male as well. Okay, how UV radiation cause skin damage? You have two types of UV, UVA, UVB. B cause DNA damage, UVA deeper in the skin. The other thing is tanning beds or solarium beds. I think they're not anymore in Australia, but I think that when I do skin check, I always ask my patient, have you ever had used solarium bed before? Most of them, they use them only for a short period, and most of them, they are more of female, not many males. But I think that's why they ban them from here because of risk of skin cancer. All right. When the patient comes to do a skin check, there is a risk assessment. Okay, so we'll ask the history from the patient, history, exposure. So because I work in rural Victoria, which is Kyneton, so they're all farmers. So they can't, he's farmer, they're not good with the sunscreen. Family history, immunosuppression, skin type, and past history of skin cancer. This is beautiful explanation of what we call Fitzpatrick scale of skin type. So we have type 1, type 2, type 3, type 4, type 5, type 6. Basically, type 1 is the very fair, always burn, never tans. I think most of us from Middle East area, we are type 2 and type 3. That's why the risk of having skin cancer is less. But I think even though we have to, I think the most important thing is about prevention is we have to stick to sunblock. All right. Skin check. Okay, so the patient comes, he's booked for skin check or a lesion check. So basically what is skin examination. Make sure we examine the skin because it's sensitive area, and most of the patient they have to undress if they're comfortable with that. So we make sure that it's privacy, good lighting. Some people they might ask for chaperone. That's fair enough. Ask the patient history. Why are you here? What's your concern? What's the lesion? And history of skin cancer, because anybody who's got history of skin cancer increases risk to develop more skin cancer. So that's why if anybody comes to cut up, let's say a BCC or SCC apart from melanoma, I usually ask to see them in 3 months or sometimes every 3 months for the first year, and after that 6 months, and after that every year. Family history of melanomas increases the risk of developing having melanoma as well. I think the studies cite 4 to 7%. And medical history, sun exposure. And when we ask about sun exposure, a number of, let's say, when last time you had the sunburn, and as we know, sunburn, there's degrees of sunburn. The bad one is the most important one that we should ask, when was the last time? And the other thing is occupation, because as we said, farmers, all these kind of outdoor workers, and the skin type basically, all right? The other thing is we'll do the skin check, and as we'll do the skin check, basically in terms how we do the skin check, everybody got his own approach. I think maybe me and Zeyad, we do in a different way, but the most important thing is to examine all the skin. All right, and the other part usually most of us sometimes we don't do it. Usually asked to open the mouth, check for mucosa as well. Especially smokers, they might develop SCC on the lips. I think which is very, very important. And the other thing is documentation. It's really important. And nowadays with the advanced technology, we can take photos. And sometimes what I do is I ask patients to take photos with their phone, and then when they come back, we'll check them. Dermoscopy. Okay, what's dermoscopy or dermatoscopy? It's basically an non-invasive method to view and evaluate color and microstructure of the epidermis, dermoepidermal junction, and the papillary dermis, which we can see by our naked eye. Like if the patient comes, he's got, let's say, a seborrheic keratosis. Okay, it's seborrheic keratosis, but maybe when you put your dermatoscope there, you might find some other finding as well. So benefit are of dermoscopy is improved melanoma detection, reduce unnecessary excision, and easy to put in practice. Like if you look at these studies, diagnosis improved. If you by naked eye, so melanoma detected after 1 day training, let's say if you got 10 GPs, we do 1 day training. So the melanoma detected by naked eye was 54. And when they did 1 day dermoscopy was 79. And melanoma missed by naked eye was 23. But when they did the training, it was only six melanomas, which is really good. All right. As we know, the most fundamental tools we use in doctor careers is stethoscope. But for skin cancer doctors is the dermatoscope, which is the stethoscope of the skin, basically. All right. So we got a couple or multiple types of dermatoscope. This is an example. Also, I prefer one of them, just for conflict of interest. So yeah, I won't mention that. But look, at the end of the day, it's your personal preference. Whatever you use, whatever you prefer, that's up to you. And this was the first handheld was developed by this guy, Brian Falco. And this was in 1989. I was 1 year old at that time, so that's good. For the last 30 years, then we have good improvement. I'm not sure what will happen after another 30 years with artificial intelligence in place, and I'm sure Zeyad and you guys are aware of what's going on. I think it's an evolving space. We'll watch the space and we'll go from there.
We may lose our jobs, James.
Sorry?
We may lose our jobs.
Yes, we might lose. We'll see how we go. Beautiful. Type of dermatoscope, we have multiple type of dermatoscope. It's non-polarized, which was the old style, which we have to use, like when you examine the patient, you have to put some like ultrasound gel to give you more clear images, and then we got the polarized. Most of the new ones, they got, like, if you look at Dermlight or Jaime, most of them now they are hybrid. You can, by pressing a button, you can convert them with polarized and non-polarized. And the new one is what we have. I use this device basically. The photo finder is the digital one. So like you take the photo and immediately, and it's in your system. And in this photo finder machine, now they embedded the AI as well. So it will help you. It will give you a guide, but at the end of the day, it's your call to either go with what they said, or it's your decision that will tell you clearly it's not our responsibility. All right. How dermoscopy works. Okay. What happens if you don't have dermoscopy? With the naked eye, you know, when we look at any lesion, there's reflection. All right. But when the important structure of pigment that are hidden in this stratum corneum, which is the top layer of the epidermis, and what happens when we use a dermatoscope is magnifying glasses. The handheld dermatoscope, they magnify by 10. They have strong lighting. The one with photo finder, the one I showed you, this one is 20 times magnified. This is a special one, but it's very expensive device. It's around $80,000. So I think it's not most of the GPs, they can afford to buy this, and it's not necessarily, to be honest, if you are not specialized as skin cancer clinic. All right. So what will happen is the dermatoscope is, as said, is a magnifying lens with strong lighting. If you use polarized light or immersion fluid like alcohol or gel, it reduces the surface reflection, and this let us see into epidermis and superficial dermis as well. I think when we have look for it, it will be more clear. All right. What we can see when we use a dermatoscope, we can see pigmented network, we can see vascular pattern like abrasing vessels, dotted vessels, polymorphic vessels, and we can see sometimes structure which cannot be seen by naked eye. I think this is a good diagram how it works. So basically, if you imagine this is our eye, this is the lens, this is the light. Okay, so you got the light here. So you got the light source, and this is the lesion. This is the fluid that we put like alcohol wipes or gel, and then they got a special lens here that absorbs the reflection, and then you can see a little bit inside the lesion, which make our life easier. All right, how it works? Like dermoscopy. When I start training in doing my dermoscopy training, I said, what's going on? There's a lot of names, a lot of structures. I'm confused, but it's easy. How it works then? So people, they gathered and they came and they said it's algorithmic approach. What does that mean? Like when we have algorithms, and this algorithm based on the presence or absence of the features that we're looking for. Let's say, look, these are a lot of them. So these are the history basically of when they start doing the algorithm, because everyone will say this is BCC, the other one will say this is not BCC, this is melanoma. So they came and they put some features to see what's going on. So I think most of us know it's ABCD rule, and then I like chaos and clues and the reverse pattern analysis. I think that if anybody do dermoscopy training, I think they concentrate nowadays on chaos and clues. This is Australian. Was by Ross Handel, which is the guy who who runs the Master of Skin Cancers Medicine from University of Queensland. So I like this approach. And also the other one is the revised pattern analysis by Kettler. All right. I know we don't have much time, but I just need to concentrate on the 3 common skin cancers, which is basically BCC, which is the common one, squamous cell carcinomas, and melanomas. So this is the dermoscopy of basal cell carcinoma. So if we can see here, I think so. Can you see my point here? Yeah. So if you look at this one, can you see these blood vessels? This is the normal skin. So when you put your dermatoscope here, this is the normal skin. If you look at this lesion, you can see these arborizing vessels. It's sharp demarcated vessels, which this is one of the signs of when we look at any lesion to exclude. This is one of the common signs to see when we check any lesion for BCC. And the other thing is we can see this blue ovoid nest and any ulceration. Any ulceration, it might be a sign of basal cell carcinoma. The other thing I want just to concentrate, I see a lot of patients, they come to me, non-healing ulcer, seeing by another GPs, just saying it's an infection, just keep giving them antibiotics, and then they're not healing. So basically, my message is, if you got a patient who's got non-healing ulcer, I think it's a good idea to do a biopsy, just to rule out cancer. If anything stays more than 6 to 8 weeks, you're giving him antibiotics, you're giving him steroid. I think just either refer or do a biopsy. That will save a lot of time for the patient and the money as well. This is the squamous cell carcinoma. So with squamous cell carcinoma, most of them they have keratin, they are white. Then you got this, you can see if I think it's a bit tricky, but you can see some vessels around. Let's imagine, usually when I look at any lesion, so it's a clock, it's 12 o'clock. So if we look from 6 to 11 o'clock, there's some vessels, and you can see some ulceration, and the yellow one is the keratin. Last one, typical one, melanomas, the killer. All right. So if you look at this photo, like with a naked eye, I don't think so we can appreciate any of these features without using dermatoscope. So I think that's why dermatoscope it's really vital to diagnose early melanoma. And when we diagnose early melanoma, we save patient life, we save a lot of burden on the health system. So if we look at this lesion, we say these are all dermoscopic terms: atypical pigmented network, irregular streaks, multiple colors. You can see if you got any lesion who's got multiple colors, I think this is one sign of the one sign to do a biopsy. And if you look here, look at the shape of this lesion, this one and this one as well. If you see blue, mean that the melanin is very deep. So it's a reflection. It's a reflection of light. If you see any lesion who's got blue color in it, I think it's a good idea to biopsy. And if you're not aware of any, if you're not training in doing a biopsy, just refer the patient. I think that's a good idea. All right. Sorry, it's a very fast-paced presentation. What's the benefit of having dermatoscope in GP land? So it improves the accuracy and the confidence. It reduces the referral and the excision and enhance patient educations. So basically, if you know how to use the dermatoscope, like let's say, if you get patient comes, he wants to check a lesion, you know that's seborrheic keratosis, you can do cryotherapy, and that's the end of the story, rather than refer the patient and save time, save money, and the patient feels happy as well. He might refer another patient to you. What are the limitations? So the limitation basically is learning curve, and it's not 100% diagnostic, and require ongoing training and practice. And as Zeyad say when he started see a lot of lesions. I remember when I started doing skin cancer, I used to do a lot of biopsies, but after that, when your eye is trained, you see, this is not when, like, I see a couple of my colleagues who they start now, they're very anxious. They ask me about advice. They come ask me, James, do you need to biopsy? I say, no, don't do biopsy. And sometimes they do biopsy and they tell me the result. I say, look, I told you it's more of when you train your eye, you will have more experience. Like, even you do a lot of courses, but I think at the end of the day, it's practice.
شكرا جزيلا دكتور جيمس.
Sorry, just a quick one. Just to give some training courses. There's a lot of training courses. There's RICGP, there's Skin Cancer College, there's online and practical module as well. Summary, very quickly, skin cancer is common, preventable. As a GPs, we play a central role in early detection, and dermoscopy improve diagnosis. And ongoing education is really important for the patient. Take home message: think skin cancer in every consult. Do a thorough skin check. Use dermoscopy routinely if you have. Refer for a biopsy when uncertain. And please feel free to send me or ask me if you have any skin lesion. Just this is my number here. If you want, just send me. Say, hi, I'm James. Could you please help with this? If I can, I'll help. If not, I'll refer it to Zeyad.
شكرا جزيلا دكتور جيمس. محاضرة قيمة.
We're all here to help, ready to help.
We're very good lecture, both Dr. Zeyad, Dr. James. Thank you very much for your time, and it's fantastic lecture. It's just the time is a problem. I should have give you warning from the start, make it 2020, because I'm sure there will be a lot of questions. Yeah. So let's open the door for the question and see what we have.
Yeah, I'll stop sharing my slides.
You have to be firm with us, Dr. Issam. احنا عراقيين ما
It was good lecture. It was good lecture. So I will just open the door. Anyone have a question, they can raise hand, or just directly they can talk.
Can I ask a question?
Yes, Dr. Ahmed.
Yep. Dr. Zeyad, Dr. James, thank you very much for the great presentation. I have a few questions. One of them is about the striae. The striae which are not related to pregnancy, which are not related to diseases, which sometimes comes in a diffuse pattern. Do you have, Dr. Zeyad, any new development in the management of them, or in dealing with them in general?
Sorry, Dr. Ahmed, are we saying striae?
The striae, yeah.
The striae, right? You're saying? Yeah. So basically, it obviously depends on the color. They're still fresh and red. The first thing to do is you could use the same pulse dye laser that we're talking about, because this will eliminate the redness. But for the atrophic whiter one, which usually happens later on, there's a laser called Fraxel, which is more of an ablative laser that does help. It's not a magic wand, it won't disappear completely, but at least 70–80% will improve with using those two. Topical retinoids also help a lot using them, but usually they get better. Obviously, that's usually what we tell patients. But I mean, some patients are very, pushy, and they want to improve things to the maximum. Then you offer them the lasers in addition to the creams.
Do they improve spontaneously, you said?
They do get better. The color usually resolve after a couple of years, and they become less noticeable, kind of blend in with the skin, and never more. Maybe cheaper option that would be, instead of a laser, some patients we tell them you could do some microneedling. There are some, microneedling is not an expensive thing. A lot of derm clinicians could do it, and it helps. Usually, some of them mix a lot of meso or topical. Not, I wouldn't say evidence-based proof, but it does help. With eventually, they will get better by themselves.
Right.
Losing weight, obviously, that I can't advise anybody about. I'm not the best person to give advice about that.
Yeah. Okay.
ممكن سؤال؟
دكتور أحمد، عندك بعد سؤال آخر لو
أنا عندي سؤالي بس على the other session we have about plastic surgery, and this is also directed to Dr. Zeyad. You know the Botox and the fillers. I don't know what the position of the dermatologist in relation to the recurrent use of Botox and filling in relation to the skin health and the effect on the collagen.
Yeah, there has been a lot of studies with fillers showing that the recurrent use of fillers actually induce more collagen production and that the stretching of the skin will actually. But on the other hand, as you know, there is a lot of things. Maybe especially in Australia, what I found like to be true is a lot of dermatologists so busy with the diseases and the skin cancers, because there's so many, that very few of them actually end up doing just purely cosmetics. I think I'm seeing more complications because I mean, some nurse practitioners are amazing and they do a very good job. But I'm seeing a lot of, using, especially when they use the fillers, using the wrong product, not at the right depth. You're seeing those granulomas, foreign body reactions, hopefully less and less vascular occlusion by the fillers. But I think fillers, debatable. Botox is a lot of studies that shows that, recurrent use of Botox does eventually improve the lines. They become less and less accentuated, those dynamic lines that we use them for. I'm not to my knowledge that has any effect with the collagen production. That would be mostly fillers. There's a lot of fillers, not hyaluronic acid fillers, that our filler category of fillers that stimulate collagen production, like polylactic acid, or we used to call Sculptra. So a long time ago in New York, when it was first introduced, I was doing my fellowship there, and it was like very rare to use Sculptra, and for some reason it didn't pick up, and the product went under the radar. But now, in the past year or two, it is one of those medications to give you more natural look without filling anything. You're just putting a medication that stimulates your own collagen production, which I think aesthetically looks much nicer than filling with hyaluronic acid.
Thanks. Thank you very much.
دكتورة ليلى العساف، عندك سؤال؟
مرحبا، السلام عليكم.
عليكم.
في عندي سؤال. في وحدة صار عندها shingles on her face. It left very, very bad pigmentations. So do you think that the laser treatment will help or something else?
So if she's like talking post-inflammatory, hyper or hypopigmentation. Hyper. Usually they get better within a couple of months by themselves, depending on the skin type, right? So darker.
It has been there for a few years.
Oh, really? Maybe there is some atrophy or scarring also?
I think there is a bit of muscle atrophy, yes, where the zygomatic arch is.
Yeah, in that case, I would say mostly an ablative laser could help.
Ablation.
Yeah, but usually, with pure pigmentation should go away by itself, unless there is some atrophy going on there that is accentuating that.
So maybe a filler will work better.
Is it more like atrophy in the area?
It's actually both of them. Where the zygomatic arch is, there is a bit of atrophy, but the pigmentation is still there from the zosa.
Sometimes if it's like very deep, a fat transfer would be the best option there.
What is it? What's the option? I have
a fat transfer. Yeah, that'd be more logical.
That's for the atrophy, right?
Yeah, or radius, which is a kind of filler like calcium hydroxypatate, which is basically calcium, putting it on a much deeper. It gives you more filling, lasts up to 2 years than a regular hyaluronic acid, which won't last that long.
And what about the pigmentation?
Pigmentation is tricky. There is the pico laser, the nano wavelength laser that is more supposed to be more advanced than a Q-switch laser. It helps with pigmentation, but it's kind of a two-edged sword, if I may say. So sometimes it actually causes a paradoxical reaction, like in melasma or solar lentigen. So always I tell the patient, we'll try it for, if it's just purely pigmentation, we use it, just do a spot treatment. And more than 50% they get marvelous result, but sometimes it doesn't work. I don't know why. I think it depends on sometimes the heat itself could activate the melanogenesis or the melanocyte to produce more melanin. And it also depends on the skin type itself. So it's kind of a hit and miss, but I think it's worth also trialing a pico laser.
Pico laser. I was actually not very sure that laser is a good idea because it may precipitate those again, the shingles.
Usually it's very rare to have, it's super rare, right, to have it again and again, the herpes zoster. Saying that with the vaccination, and I'm not so sure, James may help me on that, or some, like in Australia, is it 55 years of age that you get the Shingrix covered? Yeah, so I think encouraging all the patients, because I've never seen, like most of the patients who come to me, they haven't been vaccinated with the Shingrix vaccine. And usually it's a very good idea, I think. I think it's new also. It hasn't just a couple of years, because the previous one was a life attenuated one that causes some problems, but the Shingrix actually works amazingly. I think we should encourage our patients to,
injections,
دكتور زياد عندي سؤال لك.
يب.
ماس اكتيفيشن سيندروم، هل نشوف حالات ماس اكتيفيشن سيندروم؟ لا ما تجمع.
ما شفت بصراحه باستراحه بكندا، يمكن اشتغل بتيرشري كير سنترز مرات، بس مو كثير. ما يعني not complaining that I'm not seeing them, to be honest. It's very tricky to treat.
Very difficult. Yeah. All right. We have a couple of questions in the chat. Lachlan Smith asks, hi, thanks, asking about Retrieve cream, estrogen cream for collagen building in elderly skin. Did anyone try?
The Retrieve, like a tretinoin, right?
Retrieve cream.
Tretinoin, I believe they're talking about, if I'm not mistaken. James may know.
Estrogen cream?
Estrogen cream, yeah. I mean, there is a couple. I don't think there is a solid evidence. I mean, there is some talk about it, but I don't think it's very well established. Retrieve, definitely. Retrieve, if I'm not mistaken, is a retinoin cream, yeah.
Retin A.
Yeah, so that definitely there is, whenever a lot of patients come and ask, what's the best thing I could use for my skin? And I just tell them, if you want to keep it simple, vitamin A, because all of those L'Oreal, I don't know, clinic, they charge a couple of hundreds of dollars for rejuvenation, and I don't know, whatever they say they do. And the thing that is doing the heavy lifting is basically the retinoid inside of that mixture. So usually I tell them, just use this. But the problem with our ladies, especially Iraqi ladies, our Iraqi community, they don't like cheap things, right? So a topical retinoid, just to use it once a week with just basically some vitamin C serum for life, you get the best skin ever. We're all too lazy to do it, obviously. But yeah, that's basically what's in those magic formulas, mostly.
Yeah. Dr. Issam.
نعم دكتور أحمد.
العفو. I think our colleagues, Dr. Scala Al-Dawoodi, have two comments here. Yes. One is that the age for eligibility for a free Shingrix is 65. I don't know whether this
I think it's 65, because I think that's what I thought. It's not 55. Yeah. Otherwise, they have to pay out of their pocket.
Yeah, but I can add to that is that for patient on immunosuppression, like a lot of our patients with inflammatory bowel disease like Crohn's or ulcerative colitis, they are on biological and small molecule agents. They are eligible for free Shingrix. So patient on immunosuppression, they are eligible. Dr. Scala also comment that Retrieve is a Retin A cream.
Is there any other question?
James, I might ask Dr. James a question. Dr. James, is he?
نعم دكتور تفضل.
Yeah, Dr. James, we have, before introducing any biological agent or small molecule agent for cases of Crohn's disease, ulcerative colitis, complicated celiac disease, we do a screening. So I screen them for all the viral serology, for the gold quantiferon, for the tuberculosis.
Yep.
And it is recommended to screen the skin before introducing biological agent or some of the small molecule, because there is a side effect of some of them to develop melanoma or even non-melanoma cancer.
Yep.
Do you come across a referral of this type to check with it?
Yes, especially from the public system. So before they start them, or even from like gastroenterologist, they refer patient back to me. So this is the plan. Could you please arrange a skin check and let us know if there's any suspicious lesion? Do a biopsy before we start. Yeah, I do see a lot of this.
So you check the whole skin?
Yeah, I'll check head to toe.
Whole segment. Okay.
Yeah. Head to toe. Yeah.
Right.
Even so, like the most common when the patient comes to do a skin check, they usually keep their socks, and I ask them, do you think there's a skin there? They say yes, because I came across 2 acral melanomas, which was basically like the patient wasn't aware of they are there.
Yep. And for Dr. Zeyad, for the AI, I don't think it will send you back home to it. It will send your dermatoscope. It might become absolute.
It's getting better and better. Actually, I wanted to ask James, because I saw that he's using the Photona. We use something called Vectra, which is basically this fancy imaging. It's very time consuming. It does a very good job. But with the Photona, not doing any, I'm not, I'm not sponsored by them or anything. I saw they have a new device called Scheme, which is like a handheld dermatoscope. Have you used that one, James?
No, I haven't used that. I think that's the latest version of Photo Finder, but
I think that might be a very good, because it's like this big dermatoscope that, like it's an iPhone, you hand it with a handle, and it has AI built in it, so you don't have to go have a fancy like system to go and have a photographer, and on the spot it will tell you, the AI. I thought it would be interesting to compare, when you use it, how much accurate it would be.
That's nice. Yeah, we'll look at that.
Yeah, let me know, because I'm sure they said they have a couple of prototypes. I asked for it. I thought they might have dropped one at your.
Yeah, that's good. That's good to know.
Thank you very much, guys. Thanks a lot.
And thank you, Professor Ahmed and Dr. Issam and James, for everything and for this wonderful opportunity. And hopefully, we're hoping to meet more and more in face, hopefully, now that we got rid of, hopefully, COVID. We didn't get rid of it, but hopefully we could meet more in person. We really enjoyed the last conference in Melbourne.
Thank you very much. Thanks for your time and all effort. It was excellent session. And to be honest, this is one of the highest attendees session there. We reached around 30 at some stage. Dr. Issam, are you still there?
I'm with you guys, but I'm
I'm pleased to announce that Dr. Issam will be our star guest on the next session. And we will keep the topic as a surprise, because it is a unique topic, really unique topic, never been tackled before.
بس حرام عليك دكتور.
ها؟
حرام عليك.
لا أنا من باب التشويق، من باب التشويق. Thank you very much. شكرا جزيلا.
شكرا جزيلا للجميع. شكرا دكتور.
Thank you everybody.
شكرا دكتور زياد، دكتور جيس، وللحضور. ونلتقي بكم الشهر المقبل إن شاء الله مع دكتور عصام.
إن شاء الله.
تصبحون على خير. باي باي.
تصبحون على خير.